to manage? Now, most of the time I see that, okay, the pH is less, start giving the bicarbonate. Now, most of the experts do not favor the bicarbonate therapy until and unless the pH is less than 7.1 and serum bicarbonate level is less than 6 millimole per liter, right? So, what is the primary management? The primary management is to restore the perfusion and increase the utilization of the lactate. It will itself consume the H plus and it will restore the HCO3 ion. So, role of bicarbonate therapy, Now, lactic acidosis, what does it do? It decreases the bicarbonate. So, what should we target? So, what should be our target? Our target should be to metabolize the lactate. This will increase the HCO3, right? And this will restore the pH. This will restore pH. So, stimulus which is causing the lactic acid accumulation should be removed. So, we should target stimulus to lactic acid production, and this should be eliminated, and this will itself correct the acidosis. So, this should be the primary therapy. So, when is the role of bicarbonate? When should the bicarbonate be given? Now, most of the expert, but not all, I would say, agrees that if pH is less than 7.1, then this causes a lot of issues, like it causes decrease in the cardiac contractility, it causes systemic vasodilatation, it impairs the impairs the effect of inotropes. So, when the pH is less than 7.1, then only the bicarbonate therapy is indicated. So, role of bicarbonate therapy is bit controversial. Role of exogenous bicarbonate is controversial. Now, most expert, they believe that if pH is less than 7.1, I am saying most expert, not all, less than 7.1, then we can go for bicarbonate therapy. Now, why we are targeting less than 7.1? Because if pH is less than 7.1, there are a lot of ill effect which causes hemodynamic instability. So, what are causing the hemodynamic instability? The less than 7.1 pH causes reduced left ventricular contractility, systemic vasodilatation, and impaired effect of the inotropes. So, reduced left ventricle contractility, atrial vasodilatation, and impaired responsiveness to catecholamine. Okay. So, this is all causing hemodynamic instability. It is causing hemodynamic instability. So, at this point, when the pH is less than 7.1, we can go for bicarbonate therapy. So, indication, what are the patient who should receive bicarbonate therapy based on this recommendation followed by most of the expert? There are two indications of bicarbonate therapy. Number one, if pH, as I said, less than 7.1 and serum HCO3 less than 6 milliequivalent, right, per liter, then we go for bicarbonate therapy. 2, if pH is between 7.1 to 7.2 in patient with acute kidney injury, right? If patient is in acute kidney injury and pH is between 7.1 to 7.2, the bicarbonate therapy has shown to reduce the requirement of dialysis and it's improved the survival. So, the bicarbonate therapy has improved the survival and decreased the requirement of dialysis, right? So, these are the two indications of giving the bicarbonate therapy. So, what is the therapeutic goal? What should we achieve when we are giving the bicarbonate therapy. The primary goal is to increase the pH, right? Now remember, bicarbonate therapy is to increase the pH, but you have to be very careful in giving the bicarbonate. It's a hyperosmolar solution, plus it is soda bicarb, which is most commonly used, so it can impair the electrolyte balance of the body. It can have a lot of effects, so we have to give it the bicarbonate therapy with a careful monitoring. So what is the therapeutic goal? Now bicarbonate therapy, bicarbonate is used to keep pH above 7.1 in normal, and in patient with AKI, pH above 7.3. So what is the dose? So how do we calculate the dose? Simple, 1 to 2 millicoulomb per kg body weight. 1 to 2 millicoulomb per kg body weight of sodium bicarbonate we give, and we repeat, right, 1 to 2 millicoulomb per kg body weight, and we repeat it after 30 to 60 minutes if the pH of the patient has not improved. So this is our therapeutic goal, right? Now what are the potential harms of bicarbonate therapy? What are the problems of bicarbonate therapy? What are the things that we need to look for? Now there are 4-5 important things that we need to take care to have an optimal effect of bicarbonate therapy, even when it is indicated in the patient. So what are the potential harms we have to understand, and how do we remedify that harm? What should be our approach? So number one is that giving bicarbonate increases arterial and tissue capillary partial pressure of carbon dioxide, which can be negated by optimizing the ventilation of the patient, which I'll talk about. The second thing, it can accelerate, it can have a paradoxical effect. It can, by increasing the pH, it removes the feedback mechanism that a decreased pH had on lactate production. So it can accelerate the lactate production, accelerate the lactate generation, right? So it can have a paradoxical effect. Then it can reduce the ionized calcium, which can again affect the myocardial contractility. So it can reduce ionized calcium, and since it is sodium bicarbonate, which is most commonly being used, so it can increase the serum sodium level, and it can also, it's a hyperosmolar solution, so it can also increase the volume status of the patient. So it can cause extracellular fluid expansion. So it can increase the serum sodium, and it can cause extracellular fluid expansion. Now one by one, let's see how this is happening and how we can remedify it. So first is it is increasing the arterial and the tissue capillary pressure of CO2, right? And this can be negated by hyperventilation. See, when we give the bicarbonate, there are several steps which reactions takes place in the body before the correction of the pH. What happens if when we give the bicarbonate, how does it increases the PCO2. Now HCO3, which you are giving, it is reacting with the H plus ion, and it is causing the formation of H2CO3. This is converted into carbon dioxide and water. Now this carbon dioxide should be removed from the tissue and the capillary bed. If it is not removed, what will happen? This reaction will get affected, and what effect we want on the pH through the bicarbonate therapy we will not get, right? So if CO2 is not removed, right? If CO2 is not removed, it will increase the PCO2. It will increase the PCO2, and pH will not get reduced, So our aim will not be achieved. Now, apart from the managing the ventilation by removing the carbon dioxide, adequate perfusion should be restored as soon as possible, because exchange will not happen until unless blood is carrying that CO2 from the tissue and the capillary bed to the pulmonary capillaries. So restore the perfusion. So consequently, along with it, adequate perfusion and ventilation is prerequisite to have good effect of exogenous bicarbonate, right? So we need to have adequate perfusion and ventilation along with this bicarbonate therapy while treating the patient. Okay, now acceleration, second problem I said, acceleration of the lactic acid production. Well, it is removing the feedback mechanism. Acidosis was decreasing the lactic acidosis, the lactate production. Now it is increasing the pH, and that feedback or that feedback is removed is removed and increase acceleration of the lactate production. So acceleration of lactate generation. Now I said the acidemia, the patient's pH was less, that was the brake for the lactate production. Now this brake is removed, the lactate production increases. So acidemia will act as brake on lactic acid by inhibiting the glycolysis, right? And this is by its effect on the enzyme phosphofructokinase, right? Now increasing pH removes this brake, and this causes increased production of lactate. So this is another problem, right? Then the other third thing which I talked about is that effect on ionized calcium, your sodium, and what is the effect on the volume. Okay, so as the pH increases, the ionized calcium reduces. So we need to get a serum electrolyte done, and we need to correct that calcium. So effects on calcium, sodium, and extracellular fluid volume. So an increase in pH can reduce ionized calcium, right? So serum, right, it can reduce ionized calcium, so we need to correct it. Now apart from that, what is the effect on sodium and extracellular fluid? So we are using what for most commonly? We are using hypertonic solution of sodium bicarbonate, 8.4% solution of sodium bicarbonate. To understand what is the pharmacology of sodium bicarbonate, you can refer to the video separately on sodium bicarbonate in the pharmacology section. Here I am just telling that hypertonic solution, 8.4% of sodium bicarbonate we are using. Let's say 50 ml, which is in one ampoule. If I am using this 50 ml ampule, 1 ml containing, let's say 2 milliequivalents whatever of sodium bicarbonate, this 50 ml ampule, if I am using, this increases serum sodium by 1 milliequivalents per liter, and this causes volume expansion. It's a hypertonic solution by 250 ml. 50 ml will increase 250 ml of extracellular fluid volume. So volume expansion of 250 ml. So depending upon how much you have given. So if I have given 150 ml of the sodium bicarbonate, 3 milliequivalent of serum sodium will increase and 750 ml of extracellular fluid volume will increase. So we have to be careful, especially in patient with, let's say, congestive cardiac failure. It can deteriorate the patient and it can cause hypernatremia, which will further deteriorate these patients. So you have to be very careful in using sodium bicarbonate as well. Okay, so what could be the alternative to this sodium bicarbonate, where we don't want the volume expansion and we don't want the serum sodium to increase? So there are some other buffers as well available. Now, one of the alternative to sodium bicarbonate is promethamine or tris, that is THAM, is an amino alcohol that buffers the protons by virtue of its amine NH2 and its pK is 7.7. The advantage is that unlike bicarbonate, which generates carbon dioxide, this doesn't cause it. This reduces carbon dioxide. So in patient in whom ventilation is at optimum, you cannot further change the ventilation. THAM could be a good alternative. Then we have carb. This is equimolar mixture of sodium carbonate and sodium bicarbonate that generates less carbon dioxide than HCO3. Then we have dichloroacetate, which is an investigational drug that increases the activity of the enzyme pyruvate dehydrogenase, therefore accelerates the mitochondrial oxidation of pyruvate and lactate metabolism. So this is accelerating the effect of the pyruvate dehydrogenase, the activity of the enzyme. So this is still in investigation, right? So these are the alternative to sodium bicarbonate. Now, how do we approach? So I told you when we should indicate, what is the dose, what are the issues, what are the problems, but we need to understand what would be the right way of using sodium bicarbonate therapy. So what should be the approach? Before giving the sodium bicarbonate for treatment of a patient in lactic acidosis, the ventilation should be adequately corrected. So assure that patient is adequately ventilated. Assure patient is adequately ventilated. Little hyperventilation will not harm the patient. Assure patient has adequate ventilation. So patient is adequately ventilated. Okay. Then sodium bicarbonate would increase the pH, so hypocalcemia, which can cause decrease in myocardial contractility. So calcium supplementation may be required in the patient. So as the HCO3 increases, pH as the HCO3 increases, pH increases. This decreases the ionized calcium. So this would have adverse effect on the myocardial contractility, on hemodynamics. So we need to correct the calcium level. Then monitoring. So when you are giving, there can be effect on calcium, can be effect on sodium. So we need monitoring. So serum electrolyte monitoring is must. Serum electrolyte and blood pH for the effect every 30 to 60 minutes. And we can repeat the dose if the pH is still less than 7.1. So when we have to think about these three things. We have to give the sodium bicarbonate, and after 30 minutes we will again repeat the ABG and see the blood pH and serum electrolytes, and I can repeat it. I can repeat the sodium, the pH is, if still less than 7.1, I can repeat if pH is still less than 7.1. Now let's say if no response after number of ampoules of sodium bicarbonate, no response, then what is the option? Now problem is that if we go on giving sodium bicarbonate, the volume expansion and serum sodium level will be much get affected. So there are few options. We can use a near isotonic sodium bicarbonate. We can accompany the bicarbonate therapy with dialysis, right? So near isotonic sodium bicarbonate, what it is? If several doses of sodium bicarbonate does not increase pH more than 7.1, further solution of sodium bicarbonate can be given after making it near isotonic. isotonic. So how can I make it near isotonic? Obviously by mixing it with the dextrose. So 3 ampule of sodium bicarbonate, that is 8.54% sodium bicarbonate, is mixed with 1 liter 5% the dextrose solution. So what we get? We get 150 millicoulomb per liter of sodium bicarbonate in dextrose solution, and this is near isotonic, right? So it will not affect the tonicity, but volume, 1 liter volume overload is possible, right? So in that case, if possible, patient is not improving, we can start the CRRT, right? The continuous renal replacement therapy. This will maintain the hemodynamics, will not let the volume overload to happen, and remove the other toxin, etc. also. So it can have multiple benefits. So if volume overload, right, and kidney function is impaired, we can go for dialysis. And in ICU patient who are not improving, definitely CRRT would be good. Now this benefit of CRRT would be we can administer HCO3, that is bicarbonate, and maintain volume also, right? We can maintain the volume and we can give HCO3. We can avoid hypertonicity, avoidance of hypertonicity, and calcium level can be maintained to normal, right? The calcium level can be maintained to normal, and removal of toxin associated with lactic acidosis. So all this benefit we will get. So dialysis can be accompanied. So this is how the bicarbonate therapy is planned in a patient with lactic acidosis. So I hope you have understood, and now you will use bicarbonate therapy in lactic acidosis in more scientific manner, right? Thank you so much for your patient listening.